Well, without further ado, let's go ahead and get started this morning. We are very lucky to have Drs. Ji Y Yang and Meredith Pearson join us today for a MKSAP GI session. And so I'll let Dr. Yang share your screen and take it away.
That sounds good. Nice to meet all of you. I've had a chance to maybe work with a few of you guys so far. Like Courtney said, I'm Yihan. I am actually, similar to some of you, a new transplant to Seattle. I just moved here from New Haven, Connecticut, and just started with the hospitalist group here. I'll let Meredith also just say a couple words just to introduce herself as well.
Yeah, thanks. I don't think I've worked with any of the interns. I'm Meredith. I'm one of the third-year GI fellows. And this year I'm doing my third year of GI as transplant hepatology. They have like a fast track option where you can do that as your third year of GI instead of doing an extra fourth year. So my year is all transplant hep, but nice to see and meet you all.
Okay, before I jump into the MKSAP session, something that I will sometimes do before rounding or teaching is just have a chance for some of y'all to share a moment of joy that you've had in the last week or so. I think oftentimes it's tough for everybody to get together and see each other, and it's just nice to hear about what's been going on in each other's lives. Maybe just like 1 or 2 minutes, and then we can jump into the actual teaching stuff.
I can start. Yesterday was the last day of H wards. And I went out to dinner with my fiance afterwards, and that was great. That was like the first time doing anything outside of the house in a long time. I like didn't even know how to talk to the waiter.
Thank you for sharing, Thomas.
Last weekend, a couple of my co-interns and myself got together and carved some pumpkins after going to the pumpkin patch. So that was wonderful.
I just got out of the MICU and I was on call the last night of the rotation, and my friends brought me dinner into the MICU and they didn't even need to be in the hospital that day. So that was very nice of them.
I was also finishing up nights, 2 nights ago, and then immediately took the ferry to Bainbridge and sold my car for an excellent price.
Excellent. I also just recently sold a used car as well. Okay, well, if you have other things that you want to share, feel free to pop it into the chat, and I'll get started. Just start sharing my screen here. Okay, so today we will be doing some GI MKSAP review sessions. I think for some of you, this might be the first GI MKSAP review session that you're joining. So basically the way that this is formatted is there are questions from MKSAP that I've pulled out with a GI theme. And then there'll be some polls after each question for you guys to answer, to pick the correct answer, and we'll go through and review some of the key concepts for each of those questions. Particularly for this session, we may not get through all of the questions, but the main objectives that I'm hoping that you all will pull through as we go through are listed here. First, to recognize some common etiologies of dysphagia. 2, appropriately time initiation of screening colonoscopy. Evaluate a patient with dyspepsia who is younger than 40 years old. To compare and contrast PBC and PSC. Determine when to give antiplatelet or anticoagulation agents in some common GI scenarios. And then if we have time to get to this last point, identify patients with chronic Hep B who warrant therapy. The way that I picked some of these questions are, well, one, if they might be potentially questions that you'll see coming up on board exams, or if they may be clinical scenarios that you may run into either in the outpatient or inpatient settings. I will say, if you guys haven't had a chance to go through too much of MKSAP, is that these questions are pretty tough. They're actually harder, I found, than the actual board questions that you'll take after residency. And some of these questions in particular that I had pulled out are ones where across sort of the national average, there was a wide sort of spread in terms of how people chose the answers. So as you're going through, if you're not 100% sure, definitely don't feel bad at all, because like I said, some of these questions are definitely pretty tough, okay? And then Meredith will be also here to give some of her GI expertise as well. If you have questions or other comments, feel free to also put them in the chat. I won't be able to see the chat very well because I'm sharing the screen, but Courtney will be sort of reviewing that and letting us know to stop and answer any of those questions. So feel free to either unmute and interrupt if you have a question, or just type it into the chat. All right, for some of these questions, I'll probably just ask for a volunteer to read so that it's not just me as a talking head.
A 55-year-old man is evaluated for progressive dysphagia for 2 years. He has dysphagia to both solid and liquids. He has cardiomyopathy with an EF of 15%. His medications are pantoprazole, furosemide, valsartan, digoxin, metoprolol, low-dose aspirin, and amiodarone. He is unable to walk up 2 flights of stairs without stopping. He does not drink or smoke. His blood pressure is 100/65, heart rate of 90, BMI 32. Exam is remarkable for fine crackles at the lung bases posteriorly and a third heart sound, and 2+ pitting edema in the knees. Upper endoscopy shows no masses. A barium esophagram is shown.
I will go to the next slide, which shows the esophagram, and then question there.
Oh my.
So the question here is, which of the following is the most appropriate treatment? A, botulinum toxin injection, B, calcium channel blockers, C, endoscopic pneumatic dilation, or D, laparoscopic surgical myotomy. And let me see if I can. Are you guys able to see a poll pop up? Perfect. Okay, so I will go back to the question too, in case you guys want to see that as you're looking at the answers.
I'll give maybe another 10 seconds. We're almost to a quorum here from answers.
All right, so it looks like 57% chose endoscopic pneumatic dilation, laparoscopic surgical myotomy, and was 21%, and 21% also chose botulinum toxin injection. All right, great. So the correct answer to this question here is botulinum toxin injection, which is also, I think, the answer choices here were pretty much how like the national average spread also was. So for those who chose botulinum toxin injection, does anybody want to briefly say like why you ended up choosing that answer?
I think it's because when I was thinking of like because you're just looking at like the sphincter is just like contracting too much, isn't it? And so then you're just using the botulinum toxin to relax the muscles down there. Is that, I don't know.
That's correct. Yeah, you have sort of increased sphincter tone. Yeah, and so
what's the condition? Yeah, sorry.
Yeah, go ahead.
Oh yeah, the achalasia.
Excellent. Yeah, so this classic description here, you know, of dysphagia to solids and liquids, and this sort of bird's beak appearance is what you would possibly see as the description for achalasia. All of the answer choices are potential treatment options for achalasia. So I think, Meredith, if you want to comment on sort of how you might sort of choose botulinum toxin for this patient rather than dilation, which I think is definitely one of the more, I think, common treatments.
Yeah, and I don't want to like overstep what you're going to be teaching about later, but essentially what somebody put in the chat is kind of the right answer. They're a poor surgical candidate. So when you're thinking about treatments for achalasia, then the main ones that you're thinking about are botulinum toxin, pneumatic dilation, surgical myotomy, or now more recently something that we're doing within our endoscopic field, or at least the therapeutic endoscopists are, something called POEM, stands for per oral endoscopic myotomy. So basically it's very similar to a surgical myotomy, but they can do it all endoscopically without any open incisions. But you need to think of course, the surgical myotomy, the POEM, and the pneumatic dilation as all just being done for patients who are surgical candidates, because pneumatic dilation has a small but not insignificant risk of perforation. It's not the same as our kind of normal dilations that we do for just kind of like a benign stricture. And so that's why you want to make sure that they are a surgical candidate in case something goes wrong during the pneumatic dilation.
Great, thank you. Yeah, so I'll pull up a table that goes through some of the pros and cons and some of these treatment options for achalasia. So first, medical therapy, things like calcium channel blockers. The main con is that these are the least effective treatment option out of everything else, and they aren't super durable, but they are relatively low risk, and they're potentially good options for patients who aren't operative candidates. And similarly, for other patients who aren't good operative candidates, botulinum toxin injection can be an option. It's a relatively short procedure, and the effects last for about 6 to 12 months, which is sort of the downside, as it's not as long lasting. You get to some of the more procedural, surgical, or more invasive therapies after that. So pneumatic dilation, basically this is the most effective sort of EGD option. The effects last for a good while, for about 2 to 5 years. But there is, like Meredith mentioned, a small risk for perforation. And if a patient has perforation, then they have to go to surgery. So in this patient, because of his cardiac history, we wouldn't necessarily want to have to take him to surgery if he were to experience a perforation from pneumatic dilation. But I think for somebody else who didn't have some of the risk factors that he did, this would probably be one of the first line therapies that might be pursued for achalasia. The next option is surgical myotomy. And then the effects for this last about 5 to 7 years. It's a slightly longer procedure and requires general anesthesia and potentially a hospital stay. And then lastly would be esophagectomy, which is for really end stage disease and carries a lot of risks in terms of the surgical procedure. So if you're looking at a treatment algorithm for achalasia, basically your first branch is to decide if your patient would be a candidate for surgery or not. If they aren't a good candidate for surgery, then oftentimes the first option is doing the Botox injection. And then if they are a candidate for surgery, then you can either go to the pneumatic dilation or potentially myotomy, depending on other sort of risk factors. And Meredith, I wasn't sure if you had a comment about sort of how you guys decide on dilation versus myotomy.
Yeah, so oftentimes I guess the patients that we're seeing in clinic from a GI standpoint, either for dilation or for endoscopic myotomy, didn't want the surgery, because surgery still is kind of, I think, like the first line. We have the most data on it. It's the most durable, as you mentioned. So then it kind of becomes patient preference from the endoscopic myotomy, and it's not covered by a lot of insurances yet. And so then dilation ends up, or pneumatic dilation ends up being kind of the best endoscopic option that we have, but surgery is still kind of first line in general.
Questions so far about this first section in terms of the diagnosis or treatment for achalasia?
And also just a quick point that even though that barium swallow is like very classic for achalasia, you should still send your patient for manometry just to confirm the diagnosis. It's not usually that classic either.
Good, thank you. All right, for the next slide, I just put together a couple of sort of what we call classic pictures that you might see in some board review questions or your board exams. And they'll often, sort of the question will often be, you know, somebody's coming in with dysphagia and they show you this picture either from an EGD or from a barium swallow, and they'll want you to identify what the diagnosis is. So we can go through, and if you want to shout out as we go through for each of them, or put it into your guess in the chat what the potential diagnosis is. So I'll describe a potential clinical scenario. So in this A picture, typically a younger patient, maybe 30 or 40-year-old, who's coming in with dysphagia, and what they'll classically describe as sort of this multiple rings in the esophagus on an EGD. Any guess as to what this might be?
Maybe the 30-year-old male also has a history of dermatitis or some allergies.
Some other buzzwords that might be associated with this diagnosis are what they call felinization of the esophagus, or like a tracheal appearance of the esophagus.
Yeah, people got it in the chat.
Okay.
Eosinophilic esophagitis. Yeah, trachealization of the esophagus. And I'll say, I don't know that I've seen it look like this classic on an EGD before, but it would certainly like give you pause if you were doing an EGD and you saw that, because obviously you want to make sure that you intubated the esophagus and not the trachea, but that can look pretty concerning, those like rings. And then the other thing that you'll see on endoscopy are what we call like linear furrows, so kind of longitudinal furrows in the esophagus is the other kind of classic thing you see endoscopically.
Great, thank you. Yep, and these are all different pictures, so not the same person. Yep. Excellent. And then I think for diagnosis, you basically need to have biopsies that shows the eosinophils within the biopsy.
Yeah.
Great. Okay. How about for panel B? This is a person who might have a history of, we said dysphagia, but feeling like things sort of get stuck in the chest, but also some intermittent, just sort of like they might describe chest pain that sort of comes and goes. That might get better with nitrates even. Yeah, excellent. I think some of the folks in the chat wrote diffuse esophageal spasm. Excellent. Yeah, so the classic picture here is sort of what they call this corkscrew appearing esophagus on a barium swallow. Okay, so C, I think, is pretty similar to the last picture that we saw, sort of this bird's beak appearance. And that's sort of the classic picture that we see for achalasia. What about for D? This is a person who might have a history of some reflux. Okay, I'm seeing in the chat esophageal web, and then another person with Schottky ring. Okay. Any ideas as to differences between like webs versus ring?
Is it like whether or not it's like fully circumferential within the esophagus or just like partially?
Yeah, Mac, you got that, and also location, Kim in the chat. So I think more classically, we think of rings being more in the distal esophagus, and these tend to be more circumferential. It also depends on sort of what layer of the esophageal tissue is involved. So I think classically rings can sometimes include the muscle layer as well, whereas rings might just be partially in the esophagus, typically more proximal, and only the mucosal or submucosal layer is involved. The Shotsky rings, I believe, tend to be associated with people who've had sort of ongoing reflux symptoms as well. Anything, Meredith, that you wanted to add to the distinction between ring versus web?
No, that all sounds right. I don't think I've ever seen an esophageal web endoscopically before, but I've seen several Shotsky's rings. They're relatively common, and they are very distal in the esophagus, just kind of right above the GE junction. And we treat them actually by taking biopsy forceps and biopsying to kind of like cut the ring in 4 quadrants there. So we treat them a little bit differently than just kind of your usual stenoses or strictures that you might get from like reflux esophagitis.
Great, and I think typically some patients with the Shotsky ring may experience a little bit of dysphagia, mostly to solids, and not as much to liquids.
Yeah, exactly.
All right, and how about for E? What do you guys think for E? I'm seeing cancer, malignancy, or mass. And what is it on this picture that's making you guys think about cancer or malignancy? Yeah, very irregular, narrow lumen, sort of like this chewed out apple core appearance. Great. Okay. Great. I just wanted to review some of these common etiologies that might pop up for you guys. Questions about these pictures or how some of these etiologies might present? Okay, all right, let's move on to the next question. All right, do we have another volunteer to read?
"38-year-old man presents for a new patient appointment. He has no rectal bleeding or other GI symptoms. He has no medical history and he takes no medication. His family history includes colon cancer, diagnosed in his father at age 52. All physical exam findings, including vital signs, are normal."
All right, so we'll pull up the poll question here. So the question on your poll, when should this patient undergo his first screening colonoscopy? Now, age 40, age 42, or age 50? All right, so it looks like 64% said age 42, 21% said age 50, 7% said age 40, and 7% said now. All right, so if we think about colon cancer screening, what's the typical age where we generally start? Yeah, age 50, great. For this patient, some folks said we think we need to start screening this patient a little bit earlier. So let me pull up the next slide. I also said when I first saw this question to start screening this patient at age 42, but the correct answer is to start screening at age 40. I think you guys were getting to the fact that this patient does have a history of somebody in their family, a first-degree relative who had cancer at a fairly early age. So how to decide when to start screening. So for your average risk patient, like you all said, we typically think about screening at age 50. And then for those who do have a first-degree relative who had colon cancer that was diagnosed before the age of 60, we basically choose the earlier of these two, either age 40 or 10 years before the youngest age of diagnosis. So for this patient, they had a first-degree relative who had cancer at age 52. So 10 years earlier than that would be 42, which is when I saw this question, why I chose age 42, but the recommendations are to start at age 40 or 10 years, whichever is earlier. So for this patient, it would be age 40. The other population group where we might also think about screening at age 40 or 10 years before the youngest age would be if this patient had 2 first-degree relatives with colon cancer at any age. And then if the screening is normal, there's a shorter duration between when you want to get the next colonoscopy. So instead of 10 years, it would be a 5-year interval. So
Can I ask
I
a
think
question about colon cancer screening?
Sure.
So I had always noted like the age 50 is when we start, but after oh gosh, what was his name? The actor who recently passed away who played Black Panther. There were like all these things on Twitter saying that is like screening at 45 for people who are African American. Is that from like a different society, or do you or Meredith have like some insight into some more granular screening?
Yeah, it's different guidelines give different recommendations for starting screening. I can't remember which it is. It might be like the American Cancer Society that does age 45 for African Americans. So that is kind of can certainly be considered and would be reasonable, but not all of the guidelines say that. So you can kind of, I guess, make it a patient-centered discussion if you want. And that kind of also just brings me to the point that even though this is like, a GI MKSAP question, it's really like a primary care question, because the primary care doctors are the one who need to send the patients for their colonoscopy, and so do need to know the timing of when to start. So it's something I didn't really think about as much in internal medicine until I got to GI, and it's, we only can scope the patient when they're referred to us. So yeah.
Great. Yeah, so I think basically in this question, again, thinking about age 40 as your sort of initial cutoff if somebody has a family member who had colon cancer less than age 60. Certainly if somebody had a family member who had colon cancer less than age 50, then you would start earlier. So for example, if this patient's father had colon cancer at age 42, then you would ideally start screening at around age 32 for this patient. All right. I'm just looking at the chat here. There's a question, has there been any advancement in FIT versus colonoscopy for outcomes? Okay.
Yeah, for those of you who don't know, Dr. Jason Dominitz at the VA is running like a huge national study to look at if FIT versus colonoscopy for first-time average risk screening, which would be better because there's been a lot of retrospective studies on that, but nothing prospective. So everybody is eagerly awaiting those results, but we're still quite far away from them, I believe.
Thank you. All right, let's get to question 3. Do we have a volunteer to read the question?
A 20-year-old man is evaluated for epigastric pain that gradually increased in severity over 8 months. The pain worsens with eating and is not relieved by antacids. He has no melena, diarrhea, or constipation. His medical history is unremarkable and he takes no medication. On exam, vital signs are normal. Epigastric tenderness to palpation is noted. Other findings are normal. the complete blood count is normal.
All right. And then the question is, which of the following is the most appropriate next step in management? Initiation of omeprazole, stool antigen testing for H. pylori, ultrasonography of the right upper quadrant, or upper endoscopy. Okay, it looks like there's a tie between A and B, initiation of omeprazole versus stool antigen testing for H. pylori, and then a couple who chose ultrasonography of the right upper quadrant or upper endoscopy. I guess let's first talk a little bit about what we think the diagnosis might be in this patient. Right, I'm seeing folks saying peptic ulcer, reflux, or gastritis. And then potentially also thinking about biliary colic or pancreatitis, UD versus GERD. Okay. Great. Yeah, so what features of this patient sort of were making you all think about potentially gastritis or a peptic ulcer?
There's the association with worsening of food. There's the, I guess, the epigastric tenderness, which could maybe mean a more like progressed ulceration. The severity of pain, which has been like constant and progressive over 8 months, where I think if it was GERD, it would have like kind of maybe like a waxing waning thing, and it's not improved with antacids. Could definitely be like a gastritis. The biliary colic, I guess it could be that I would think it'd be more of like a colicky type for the history, but it definitely could still be there too.
Great, yeah, so I think Max, some of the things you mentioned is sort of this postprandial epigastric pain that's sort of been progressing over the last 8 months. And certainly, I think while we think about biliary colic as being maybe right upper quadrant, I think still keeping that in mind on the differential is definitely, I think, wise, because you can still have epigastric pain there. The folks who decided on omeprazole versus, I think, testing, I think that also is where the sort of national average in terms of how people answered this question fell. There was a split between choosing a proton pump inhibitor versus testing for H. pylori. For those who decided to potentially test for H. pylori first, any particular reason why you might have chosen that?
I chose that because my understanding is if you initiate omeprazole, you might like get an inaccurate result and the treatment is different. So I was kind of thinking you'd want to rule out, you know, something that you'd need to treat with antibiotics before kind of starting a treatment.
Yeah, Rita, that's an excellent point that oftentimes for our H. pylori testing, that PPIs and other antibiotics or bismuth can cause a false negative if you do want to send a patient for H. pylori testing. So I'll show you the correct answer here is stool antigen testing for H. pylori. And this is basically recommended by the ACG that for patients who are less than 60 years old who have sort of this postprandial symptomatology like a patient did, which we would describe as dyspepsia, the ACG does recommend a test and treat option first. I think oftentimes for folks who are older than 40, we'll often empirically treat with a PPI, stronger than if they've been on Tums or some other antacids. And the main reason is because there have been a couple of trials in these younger patients where there's been a cost reduction in first testing for H. pylori rather than empirically treating with a PPI first. Again, thinking about PPIs as a treatment for just peptic ulcer disease that's not related to H. pylori. And then some of these other studies show that there wasn't a difference in prevalence in dyspepsia 1 year after some empiric PPI compared to test and treat. So because the test and treat option seemed to have some cost reduction associated with it, that's why the ACG is recommending doing this test and treat option rather than starting with a PPI. Oftentimes, the other component for H. pylori related ulcer disease is that, if you have a patient that is on a PPI and they're not getting better, then we often think of, is there some other risk factor like H. pylori that's causing their symptoms to not improve? But then we're sort of stuck also having to take the patient off of the PPI in order for our testing to be accurate. And then in terms of when we think about upper endoscopy in patients with dyspepsia, we often do an endoscopy or refer them patients for endoscopy if we're concerned about cancer or something that was more potentially sort of life-threatening than peptic ulcer. So these patients are those who are older than 60 who's got persistent dyspepsia symptoms. And then in a patient who's younger than 60, if they have a family history of gastric cancer, or if they've emigrated from a region where there's increased risk for gastric cancer. So other symptoms that might be concerning would be like weight loss or blood in the bowel movements or melena as well. That's associated with dyspepsia. All right, in terms of H. pylori screening, what options have you guys seen or used to screen for H. pylori or test patients for H. pylori? So I see some folks have used stool antigen, a breath test. And then biopsy, okay. Oh, I think William had a question. So just to be clear, I should now definitely do stool antigen for my patients less than 60 prior to starting PPI. And then, sorry, Meredith said, if they're describing symptoms you think could be consistent with H. pylori gastritis or PUD, if it's classic GERD, you don't need to test for H. pylori before a PPI. Great, thank you. So I think in this question stem, the patient had been taking some antacids and hadn't improved. So I think that is what would make us think, is there something else that's going on? I think if they had some improvement with antacids, but we're still experiencing some symptoms, you could potentially just increase their treatment to a PPI rather than thinking about H. pylori related PUD. Okay, so I think some of the options that you guys mentioned, stool antigen and breath test, are definitely the more reliable options to test for H. pylori. So there's three main ways to test for H. pylori. There's serology, the urea breath test, and the stool antigen test. If we're thinking about serologies, these are basically antibodies. They're a blood draw test. So these testing option is pretty widely available and it's the least expensive out of all three. But the one downside is that the blood serology tests aren't able to tell you if the patient has active H. pylori disease or if they just had a prior infection. And as a result, it's not recommended to check if the patient has had their H. pylori completely treated either. So between the urea breath test and the stool antigen test, both of these have pretty good negative and positive predictive values. I think ultimately what this comes down to is a little bit of patient preference and sort of what's available at your testing site. The urea breath test sometimes might be a little bit more palatable to your patient rather than having to be at home and collecting a stool sample. But basically, these are both fairly sort of sensitive and specific. They're fairly similar in terms of those test characteristics. And the one thing to keep in mind, as I believe Arita mentioned, is that for both the urea breath test and the stool antigen test, we do recommend stopping PPIs at least 2 weeks before testing, simply because being on a PPI can cause a false negative result on both the urea breath test and the stool antigen test.
I'll just add that from like a realistic standpoint, if you're seeing somebody for the first, like, and they've never been treated for H. pylori, and they're not really willing or unable to do the breath test or the stool test, it's like very reasonable to get the serology, get the H. pylori IgG. And if it's positive, even though you're right, it doesn't tell you if it's active infection now. If you have a high suspicion, then you can treat them for H. pylori and then kind of see if they clinically improve. And definitely don't ever recheck the H. pylori serology again. I've actually had a few referrals for like refractory H. pylori, and they were just basing it off of a persistently positive IgG and not retesting for active infection with a breath test or a stool antigen. So.
Great, thank you. And the reason why we bring up which tests are useful after treatment is that the current treatment options for H. pylori do have a pretty high sort of failure rate. So I think some of our best sort of quadruple therapies, up to like 30 to 40% of patients might not be able to fully get rid of the H. pylori, even if they're sticking to the 2 weeks of treatment. So it is recommended that at about 2 to 4 weeks after they complete their H. pylori treatment course, to get another repeat test and make sure that their H. pylori is no longer present. Okay. Actually, William had a question about which test is cheaper. I'm not sure either. I'm not sure if maybe Courtney, if you have a chance as we're going through to take a quick look, and we can get back to you, William, on that question.
Happy to.
Thank you. Okay, move on to make sure we're good on time here. Okay, let me move on to question 4. Do you have a volunteer to read question 4?
Sure. A 44-year-old man's routine yearly follow-up for ulcerative colitis showed elevated liver chemistry tests. He was diagnosed with ulcerative colitis 5 years ago. He has passed solid, formed stool every 1 to 2 days without abdominal pain. His only medication is mesalamine. Vital signs are normal, BMI is 26, hepatomegaly and pulmonary erythema are noted. Alk-Phos is 412, ALT is 78, AST is 462. Total billy is 2 milligrams per deciliter. His D-billy is 1.5. CBC and creatinine level are normal. Antimitochondrial antibody titer is negative. MR cholangiopancreatography shows hepatomegaly, but is otherwise normal. Liver biopsy is pending.
Excellent. And the question here is, which of the following is the most likely diagnosis? Antimitochondrial antibody negative PBC, drug-induced liver injury, non-alcoholic fatty liver disease, or primary sclerosing cholangitis? All right, looks like 69% said D, primary sclerosing cholangitis. Then we had a couple of votes for non-alcoholic fatty liver disease, drug-induced liver injury, and A, antimitochondrial antibody negative primary biliary cholangitis. All right, so I will show the correct answer here is D, primary sclerosing cholangitis. Very good. If you're anything like me, I have trouble keeping PBC and PSC sort of separated in my mind. For those of you who feel comfortable, how did you decide on picking PSC?
Well, PSC is the one that has the association with ulcerative colitis, isn't it?
Yes.
I feel like I saw like 6 or 7 patients with this at the U when I was there.
Great. So I'm going to pull up a diagram here that has some of the comparisons between PSC and PBC. Great. So I'm just going to review PSC first so that we don't get things too mixed up. So PSC, like Max said, about 80% of patients who have PSC also have some sort of inflammatory bowel disease. And if we're looking at the flip side, 5% of patients who have IBD also have PSC. Basically, PSC involves, can infect the bile ducts both inside, so intra and extrahepatic, and then doesn't really have a age or sort of gender association. We typically diagnose PSC through an MRI of the bile ducts. And then PSC is the one where we don't really have super great medical treatments for it. I think the patient in this question was a little bit sort of tricky because they didn't really have MRI findings. But the patient here they thought had sort of small duct involvement where you wouldn't see changes on the MRI and that you'd have to do a biopsy in order to diagnose. But I think the main point here is that PSC is the one that is associated with IBD. And then if we're thinking about PBC, I think the main points here is that PBC is the one that tends to have some of these antibodies that are present, so the positive antimitochondrial antibody, and only a very small percentage of patients with PBC have IBD associated with it. And PBC does tend to happen more so in patients who are of middle age and tends to be more common in women. Just wondering if anybody in the audience has had any sort of mnemonic or other memory trick to sort of help keep some of these facts separate. Meredith, have you had a way of sort of keeping some of the clinical scenarios
separate?
distinct between PSC and PBC?
I mean, I certainly remember intern year in residency, like having, I think everybody gets kind of confused because you see patients with them, and then when you're not seeing patients, it can be kind of difficult to just keep these like theoretical diseases separate in your mind. So now that I'm regularly seeing these patients, and as you will see more of them, then it just makes it more clear with experience. I don't have any like great mnemonics. I actually really love this image that you put up because I think it focuses on the really big important differences to know, primarily that PBC is far more common in women. When we're referred a male with a diagnosis of PBC, we're like already very skeptical of it. Of course it occurs, but it's just much rarer. And then another big thing is difference on imaging. So the majority of patients with PSC will have abnormalities of their biliary tract that's visible, you know, at least on MRCP, which is the most sensitive test aside from ERCP. But even on like ultrasound or CT, commonly patients with PSC will have beating of their biliary tree, and PBC, since it's a small duct disease, then their imaging will be normal. Although of course, about as was the case in this patient, you know, 10% of patients with PSC will have normal imaging, and then you would end up getting a liver biopsy to help with diagnosis. And then also it mentions on here the positive AMA, which is very specific and good for PBC. And then, yeah, no medical treatments for PSC, although they've tried to look for a lot of things, but nothing really helps. And then for PBC, the first line treatment is ursodiol. So we have something that can actually help limit progression of that disease. But both of them, you know, sometimes end up needing liver transplant. And let's see, I see your questions here.
Mm-hmm.
Yeah, PSC is definitely something that we transplant for. Yeah, and PBC too, although it's rarer that those patients progress to need for a liver transplant. And for PSC, they can kind of need a liver transplant for a couple of reasons. One is kind of the classic, they've developed decompensated cirrhosis related to their PSC. And then there's two kind of other pathways that can get them transplant, is if they have recurrent biliary infections that are like multi-drug resistant and ending them up in the ICU. That can get them points. And then the other way is if they develop cholangiocarcinoma. So, you know, we screen patients with cirrhosis for HCC, but also for patients with PSC, we look for cholangiocarcinoma as well, and that can get them a transplant. And then usual time between onset of IBD. So I don't know of the usual time. Most patients will have a history of, if they are going to develop IBD, they'll have it pre-PSC, but you can see patients who are diagnosed with PSC first and then go on to develop IBD, even patients who have been transplanted for PSC and then develop IBD after their transplant. So the kind of the pathophysiology connecting the two of them isn't understood super well. Any other questions about PBC or PSC? I think you just have to see patients, like was mentioned, you know, at the U, but you'll probably see more PSC, I would imagine.
Yeah, one way that I try to remember is just remember one and then the other is the other one. So I think what I've tried to do is for like PBC, I think of like, I look at the B and it's associated with antibodies. So like that positive AMA. And potentially, I think that then associate antibodies, maybe there's some sort of autoimmune or some other component, and that tends to be more in women than in men. And then PSC is the other one.
I think that's totally legit.
I was sharing with Kim my inappropriate one, which I won't disclose here, but I think the more PG one is for PSC. I think S stands for sun. And then it also stands for stools, like in terms of like inflammatory bowel. So there's some, and then for me, PBC is the other one because I.
Nice. Excellent. All right. I think we have time for one additional question. Let's move on here. Okay, does anybody want to read question 5?
A 30-year-old man is hospitalized for an acute failure of ulcerative colitis. He has 6 to 8 bloody bowel movements daily with prominent urgency and lower abdominal cramping for the past 2 weeks. He has been taking prednisone daily for 1 week. His only other medication is mesalamine. Vitals are normal. Abdominal exam shows lower abdominal tenderness without distension, and bowel sounds are normal. Blood is seen on digital rectal exam. Hemoglobin is 10. He's hemodynamically stable.
Okay, so the question is, which of the following is the most appropriate venous thromboembolism prophylaxis for this patient? A, aspirin, B, compression stockings, C, heparin, D, intermittent pneumatic compression, or E, low dose warfarin? All right, we've got a good split between heparin and intermittent pneumatic compression. So I remember when I was actually reviewing a similar question during residency, I also picked, I think I either picked pneumatic compression or graduated compression stockings. The answer here that completely blew my mind was heparin. And I remember thinking, like, this patient has 68 bloody bowel movements a day. Like, why would we still give them heparin? So for those who did pick heparin, what was your thought process for that?
I guess I was thinking that these guys are really prone to VTE. I don't know if this is right, but I thought they were very prone to VTE for some reason.
Yeah, you're absolutely right. So, you know, when we're thinking about what's happening in an IBD flare, there's a good bit of inflammation going on systemically. So if we're thinking about these patients, you know, we're often looking at sort of inflammatory markers like CRP or sed rate being high. So what we've found is that patients with IBD have a 3-time higher risk of VTE compared to patients without IBD. And this risk for venous thromboembolism is highest during a disease flare. And it's actually one of the more common extraintestinal manifestations of IBD. So there's the recommendation as a result that all hospitalized patients who do have a IBD flare in particular should still be given pharmacologic VTE prophylaxis with heparin. And, you know, this patient is having 68, you know, bloody bowel movements. Typically for these bloody bowel movements, they're sort of not necessarily hemodynamically compromising as far as I know from sort of the clinical presentation. So the recommendation is still to give heparin prophylaxis. You know, certainly if these patients are hypotensive or hemodynamically unstable, then we might think about holding that. But generally speaking, for patients who have bloody bowel movements as a result of an IBD flare, from a safety perspective, we still give heparin as a result, just to keep them from getting things like DVTs, especially when they're in the hospital. Anything, Meredith, that you wanted to add to this point?
Yeah, I mean, obviously I agree with all of that. And when, you know, patients are having with IBD flares or having bleeding, then it's, you know, it's not usually the same kind of bleeding, and it very rarely involves us doing like any sort of endoscopic management from a bleeding standpoint. You know, usually if we're scoping them, then it's just biopsies for staging or looking for CMV. And so, yeah, you don't kind of have to think about them usually in your usual bleeder type of patient. And then just kind of in general, heparin prophylactic dose is like fine as long as somebody's not hemorrhaging out like with a variceal bleed or something. But, you know, honestly, from a GI perspective, we're fine the vast majority of time with somebody being on heparin prophylaxis, even if they're bleeding a little bit, because we don't want them to get a DVT or a PE, and it's unlikely that that small dose of heparin is going to affect their GI bleed significantly.
Great. Okay, I'm just taking a look at the time. I think we're past the 10:30 mark, so I'm gonna stop the screen sharing here. I do have some additional questions after this, but I believe the slide deck will be made available for you guys to review as well. Is that right?
Yes.
Okay, perfect. I want to make sure I had time. Do folks have questions about the slides that we did go through at present? Okay, all right. Well, thank you guys for participating. I know we went through a good chunk of information. Just to help sort of bring home some potential key points, do some of you guys just want to hop in and say maybe one thing or one clinical pearl that you'll take away from this MKSAP session?
Stool for confirmation of H. pylori eradication.
Excellent. I see that from Kim as well.
Get the manometry in addition to the barium swallow.
Great.
Heparin's okay in IBD flares. I'd always been wondering about that.
Great.
The B in PBC is for boy, right? Or bow?
No.
Antibodies. Yeah.
Oh no, was it S? I think I messed it up already.
It's okay. Yeah, I think of B in PBC for antibodies and autoimmune stuff in women. All right, maybe one more.
You should stop the PPI for 2 weeks before the H. pylori breath or stool test.
Excellent. All right. All right. Thank you all so much for participating, and hopefully I'll be able to see you guys either in clinic or on the floors.
Thank you both so much for joining. I think we all learned a lot. The one follow-up that I wanted to give, I was tasked to find cost of H. pylori stool antigen and serology testing. So the only data that I could find close to our system was from SCCA costs. The stool antigen testing is $219 and the serology testing is $114. I couldn't find anything for the urea breath test, but there are the numbers so that you have them. And now we actually have an extended break. So we'll have everybody come back at 11 and you will be joined by the remainder of your R1 class for intern as teacher by Chris Knight. So feel free to turn off your cameras, take a long break. We'll see you back in about 25 minutes.
Ihan, I just wanted to say hello.